All right. So, good morning, everybody. So, today's session will be on the anterior abdominal wall. Okay. But I have included hernia here also. Okay. But actually, the hernia will be taken by Dr. Kumar. Okay. The topic hernia will be taken by Dr. Kumar. So, I will be covering only the anterior abdominal wall. Okay. So the anterior abdominal wall, you know that it is made up of the abdomen as such. Okay, it is made up, it's from the thorax and until the pelvis. Okay, in this presentation, I have given a full description. Okay, so try to go through it, and if you have any doubts, you are welcome to ask me back. Okay, so that's the diaphragm and the pelvic until the upper end, the pelvic diaphragm, it has been included. Okay, and these are some of the important landmarks which you should know in the anterior abdominal wall, which will be taken up in the surface marking session. Okay, so you need to, but I have given it here for your reference. So the xiphoid process, the costal margin, okay, the iliac crest, the highest point, the pubic tubercle, okay, the symphysis pubis, the inguinal ligament, the linea alba umbilicus, and the rectus abdominis. Okay, rectus abdominis, it's a muscle, so we will see about that later. Okay, and the costal margin, you know, the abdominal, the costal margin is formed by the cartilages of the 7th, 8th, 9th, and 10th ribs. Okay, and you already know that the 11th and the 12th ribs are floating ribs. Okay, and they do not have any costal cartilages which is attached. Okay, now this is an important one, the planes of the anterior abdominal wall. Okay, the planes in the anterior abdominal wall. So there are horizontal lines and vertical lines. Okay, so there are 4 horizontal lines and 2 vertical lines which we are dividing. Okay, we are dividing the anterior abdominal wall by these lines into quadrants. Okay, first let's see the horizontal lines. The transpyloric plane. Okay, the transpyloric plane. Okay, how to mark this plane? Say, suppose if you want to mark the surface anatomy of the heart, it is easy. Okay, so you know that there are ribs, so you can say that it is extending from this rib to this rib, and similarly to the lungs. Okay, it is easy. But in the abdomen, there are no bony points. Okay, but there are many structures, organs which are located inside the abdomen, for which we are making these imaginary lines to know where the organs are situated. Okay, the transpyloric plane, it's a horizontal plane and it passes through the 9th costal margin. Okay, so you know that 7, 8, 9 and 10. Okay, the 10th rib will be here. So the lowermost portion, just above the lowermost portion. So that's the transpyloric plane. It approximately passes through the L1 vertebral level. Okay, the L1 vertebral level. Okay, the next one is the transtubercular plane. The transtubercular plane is a bit easy because you can palpate the iliac tubercle. Okay, you can palpate the iliac tubercle on the right and left side and make a straight line over it, and that is the transtubercular plane. So transpyloric plane, transtubercular plane. The other plane is subcostal plane. Okay, the subcostal plane. Subcostal is the lowermost part of the ribs, and then you join a line. So that's the subcostal plane. And the other one is the interspinous plane. The interspinous plane is the anterior superior iliac spine. Okay, joining the just in front of the iliac tubercle. Okay, in front of the iliac tubercle. So you know that in the lower limb, there are many muscles which arises from the anterior superior iliac spine. So one of them is sartorius, right? So from here, join both the right and the left anterior superior iliac spine, and that's the interspinous plane. Okay, so these two planes we are not using much, but we are using these two planes. Okay, the transpyloric plane and the transtubercular plane. The transtubercular plane, as I said before, it is easy. Okay, the transpyloric plane can be tricky. Okay, so because you don't know which is the ninth costal cartilage. All right. So what some people, the surgeons, usually the clinicians, what they do is they take the jugular notch. You know, on the top there is jugular notch. Okay, in the thorax. Okay, and in the bottom there is pubic symphysis. Okay, so take the midpoint between the jugular notch and the pubic symphysis. It approximately corresponds to the ninth costal cartilage. Okay, it approximately corresponds to the ninth costal cartilage. Okay, and if you draw a straight line, so that would be the transpyloric plane. Okay, so another how to mark another making another point like how to mark the transpyloric plane would be to take the jugular notch on the top of the sternum and to the pubic symphysis. Okay, take the midline, take the midpoint between them and draw a straight line. So that would be the transpyloric plane. Okay, so these two horizontal planes we are taking out into transpyloric plane and the intertubercular plane. Coming to the vertical planes, the vertical plane it's quite easy. It is the mid clavicular line. Okay, so take the middle, the sternal end of the clavicle and the lateral part of the clavicle, that is the acromion process, and take approximate the midpoint between them and drop a straight line. So that is the mid clavicular line. Okay, so now you can see the planes, these planes are dividing the abdomen into 9 quadrants. Okay, so 1, 2, 3, 4, 5, 6, 7, 8, 9. So the abdomen is now divided into 9 regions by the transpyloric plane and transtubercular planes. Okay, some surgeons they use subcostal and the interspinous planes. Okay, but most surgeons they use transpyloric and transtubercular plane. And the vertical plane, the two mid-clavicular lines, okay, one on either sides. Now, why should we divide it into 9 quadrants? Okay, say, you know that the abdomen is like a Pandora's box. Okay, you know Pandora's box? Pandora's box, you will not know like what is inside the box. Okay, so a person coming with an abdomen pain can be due to any reasons. It can be due to liver, gallbladder, stomach, spleen, intestines, pancreas, okay, appendix, okay, but how to say which organ is involved? Okay, so for which we are dividing this into 9 quadrants. Okay, so that is to identify the location of the pain and to identify which organ is involved and to treat the patient. Okay, so that's why we are dividing it into 9 regions. So these are the 9 regions and these are the names for each one of them. Okay, all right, now let's see the plane, the region which is in the center first. Okay, so here the first one, this region, it's called epigastric region. Why it is called epi? Epi means above, gastric means stomach. Okay, so this is located above the stomach. Okay, so it is located just above the stomach. So this region is called as epigastric region. Now there are certain organs which are present in the epigastric region. Okay, example, stomach. Okay, so stomach is largely occupying the epigastric region. Okay, there could be pancreas also. Okay, pancreas is also located in the epigastric region. Okay, I'm just giving you few examples to note which organs are present in each region. So in the epigastric region, so stomach and pancreas are there. In the umbilical region, okay, the umbilical region, mostly the small intestines are located, and in the hypogastric region, okay, hypogastric region. Why it's called hypo? It's below the stomach, hypogastric region. Okay, so if it is situated here, if the pain is situated here, so what is situated? What are the organs which are located here? Urinary bladder. Okay, so usually the urinary bladder, the ureters. Okay, so they are located in this region. Okay, so there could be a pain in this. If the pain in this region can mean that it is because of urinary bladder, ureter, or the rectum. Okay, the rectum, the starting point of the rectum will be on the posterior most region, a part of the hypogastric region. Okay, so epigastric, umbilical, and hypogastric regions. Now coming to the lateral regions. The lateral part, there is upper part is called as hypochondriac region. Hypochondriac region. Okay, the right and left hypochondriac region, because they are located below the ribs. Chondral means, you know that chondra means cartilage. Okay, so right hypochondrial and left hypochondrial regions. Okay, so because they are located below the cartilage. Okay, so right and left hypochondrial region. Now in the right hypochondrial, what organs can you find? Liver and gallbladder. Okay, the liver and the gallbladder. Okay, so a person coming with the right hypochondrial pain, it could be because of a liver pain, okay, or could be because of gallbladder. Okay, left hypochondrial. What is the structures? What are the structures located here? Usually it is the spleen. Okay, the spleen. Sometimes the tail of the pancreas is also located in this region. Okay, so when we are talking about the pancreas, we will talk about that. Okay, and a small portion of the stomach also comes into the epigastric region, umbilical region as well. Okay, but mainly it is the spleen. Okay, the main organ which is located here is the spleen. Okay, the left hypochondrial region. Now the lumbar region, the right and left lumbar regions. So mainly here on this part will be the ascending colon, and here it will be the descending colon. Okay, so ascending colon, descending colon. Also posterior to this ascending and descending colon, there will be the location of kidneys. Okay, the right and left kidneys. So, okay, and from the kidneys, you know that there will be ureters which are emerging. So a right and a left lumbar region pain could mean it could be ascending colon if it is on the right side, left side it could be a problem with the descending colon, okay, or the right and left kidneys or the ureters. Okay, then inguinal region, right and left inguinal region. Okay, the right inguinal region, what are the structures? It will be the starting point of the colon, okay, the large intestine, which is called as cecum. Okay, cecum and appendix. Okay, cecum and appendix. So in case of appendicitis, usually the patient comes with a right inguinal region pain. Okay, or it is also called as iliac fossa. Okay, it is also the inguinal region is also called as iliac fossa. Okay, so you can just make a mention out of it, make a mention here. So it is also called as iliac region. Okay, the right and left inguinal, or it's also called as iliac region. Okay, because it is located above the iliac bone. Okay, the iliac bone. Okay, so the right and left iliac here on the right side means it means cecum and appendix, and in the left iliac region, what is located? Uh, it will be the end point of the descending colon, which is called a sigmoid colon. Okay, the sigmoid colon. Okay, is located here, and the sigmoid colon then leads on to rectum and then the anal canal. All right. So these are the 9 regions which you need to know, and you need to know the main organ which are located in each one of these regions. This is very vital not only for the anatomical point of view but for the clinical aspects. Okay, so you need to know like which pain, which organ could be the problem. Okay, so that's why we are dividing it into 9 quadrants. All right. Now the surgeons, they also include a 10th quadrant. Okay, a 10th quadrant or the region which is called as perineum. Okay, that is the genitals, the part between the two thighs. Okay, the perineum is the 10th quadrant or the 10th region of the abdomen. Okay, why they have included the perineum in the abdomen? Okay, a perineum is a separate reproductive organ, right? So why should we include? Because the regions here, the genital organs, they usually descend from the abdomen during embryologically. Okay, so they will be descending from the abdomen. All right, so an abdomen pain could also mean that the perineum is also involved. Okay, so in an abdomen examination you need to examine through all these quadrants: epigastric, hypogastric, umbilical, hypochondriac, lumbar, and iliac regions. Okay, and you should say that the examination is not complete without the examination of the perineum. Okay, so the perineum is a very important region, especially in clinics when you go through it. Okay, so when you go to clinical postings, you will know about this. Okay, please don't type in the chat box because I won't be able to see the chat messages now. Okay, any doubts, I will give you time. At the end, you can make a note of it and I will clear your doubts at the end. All right. Okay, so these are the 9 quadrants of the abdomen. All right. And here in this picture, I have just mentioned a few organs which are located in each one of these quadrants. So here you can see in the right hypochondrial region, mostly it is occupied by the liver. Okay, but you can see the liver is also extending into the epigastric region. Okay, similarly the stomach is mainly located in the epigastric region. However, a small portion of the stomach goes into the left hypochondrial as well as into the umbilical regions. So ascending colon, transverse colon, or descending colon, this is the sigmoid colon, and then the rectum. Okay, and here you can see the appendix. This is the cecum. Okay, and this is the appendix. Okay, which is usually located in the iliac region. Okay, so you need to know the organs and which quadrant they are present. Okay, in which quadrant they are present. All right. Now let's go. After now we have divided it into 9 quadrants. Now we will see the anterior abdominal wall. So as you know, the anterior abdominal wall is made up of muscles. Okay, it's made up of muscles. Why not bones? Why there are no bones present in the abdomen? Because the abdomen has to expand. Okay, so when we eat food, okay, the food, if there is a bony structure present inside the abdomen, okay, so the abdomen cannot expand. Okay, and there are a large number of structures within the abdomen. So it is quite difficult. Okay, so it is quite difficult to find out like what is the reason for pain. Okay, for quite reason difficult to find out what is the reason for the pain. Okay, and that's why like in order to expand. Okay, so suppose if there is we eat food, the stomach will enlarge. Okay, so it will accommodate more food. Okay, and sometimes when the liver enlarges, okay, so that will be accommodated. Okay, so the anterior abdominal wall is not formed by bone, it is mainly formed by muscles. But will the muscles give strong protection to the abdomen? Yes. Let us see like how the anterior abdominal wall provides strength. Okay. Now, the anterior abdominal wall, these are the layers which you come across if you make an incision in the abdomen on the lateral side. On the lateral side. Okay. That is paramedial side. Okay. So, if you make an incision in the abdomen, okay, on the lateral aspect, first layer would be the skin, the next layer would be the superficial fascia, which is made up of fat, okay, and the next layer would be a muscle, which is external oblique muscle, and below it will be the internal oblique muscle, okay, and below the internal oblique will be the transverse abdominis muscle. Okay, and next to the transverse abdominis muscle, there is a fascia which is called as fascia transversalis, or you can call it as transverse fascia. Okay, fascia transversalis or transverse fascia. Okay, and peritoneum. Finally, the peritoneum. Okay, inside which the organs are located. Okay, so this order you need to remember. Why? Because after the surgery, when you are closing, say you are doing some surgery in the abdomen, okay, so you are passing through the layers, you should also close the abdomen in layers. So first you need to close down the peritoneum, fascia transversalis, transverse abdominis, internal oblique, external oblique, superficial fascia, and skin. Okay. Similarly, on the medial side, exactly in the center, suppose if I make an incision exactly in the center, okay, so these are the layers which I can come across. Okay, the first one would be the skin, which is same. The second one is also the same, the superficial fascia. The third one, here, instead of external oblique muscle, there is anterior wall of rectus sheath. Okay, then below it, there is the rectus abdominis muscle, and behind it the posterior wall of rectus sheath. Okay, so these three things are 3, 4, and 5 are changing here. Okay, and afterwards it's common, fascia transversalis and peritoneum. Okay, now let us see like why it is different on the medial side and why it is different on the lateral side. First, let's look at the lateral side. Okay, in the lateral side, the first is the skin. So the next one would be the superficial fascia, which is made up of fat, and superficial veins, okay, arteries and nerves. Okay, then you come across the third layer, which is the external oblique upper muscle. Okay, so the external oblique muscle. Now, if you look into the direction of the external muscle fibers, the muscle fibers are arising from the lower ribs, okay, and it is going medially. Okay, so the direction in which the muscle fibers are going is downwards and medially. Okay, so downwards and medially. Okay, and then it's joining in the midline. Okay, it is joining in the midline. Okay, so this is the direction of the muscle fibers in external oblique muscle. Now this muscle it has got muscle fibers, and here there is a tendon. Okay, here there is a tendon. Okay, so what do you call a flat tendon? A flat tendon is called as aponeurosis. Okay, aponeurosis. So this tendon, it's called as external oblique aponeurosis. Okay, so external oblique aponeurosis. So this is external oblique muscle. This is external oblique aponeurosis. All right. The next layer is the internal oblique. Okay, the internal oblique, if you see, the origin is from below. It is arising from the inguinal ligament, okay, also from the iliac bone, and then the direction it's going opposite to that of external oblique. It is going upwards and medially. Okay, it is going upwards and medially. All right. So the internal oblique muscle, and this is the internal oblique aponeurosis. Okay, so the internal oblique muscle and internal oblique aponeurosis. The next one is transverse abdominis. As the name indicates, the muscle fibers are located transversely. They also arise from the iliac crest, okay, and also there is a ligament, iliolumbar ligament. So from there it will be arising in, okay, and the muscle fibers are located transverse. Okay, you can see that it is located transverse, and there is also transverse abdominis aponeurosis. Okay, transverse abdominis aponeurosis. All right. So external oblique muscle and external oblique aponeurosis, internal oblique muscle and its aponeurosis, and transverse abdominis muscle and its aponeurosis. I'm not going into the detail of origin and insertion, okay, which will be detailed in your book. Okay, so since this is a 1 hour lecture, okay, I'm just going a bit fast. Okay, all right. So this is the three muscles. Now, why there are three muscles? Why can't there be only one single muscle? Okay, why can't there be only one single muscle? Why there are three muscles? And these three muscles are in different directions. Okay, if you see the external oblique muscle, the external oblique muscle is passing downwards and medially. Okay, so internal oblique, it's passing upwards and medially. Okay, and the transverse abdominis is going transverse. Why? It's because to strengthen the anterior abdominal wall. Okay, so imagine if there is only one muscle. Okay, imagine if there is only one muscle. Okay, and if the person eats, okay, so the abdomen, the muscle will not be able to hold the organ. Okay, and the organ will tend to herniate. Herniate means come out. Okay, come out through the superficial fascia, and it will be projecting in the abdomen. Okay, but normally we don't see liver or abdomen, the stomach, or the colon. Okay, those things we are unable to see because these abdominal wall, they provide strength. Okay, another example is you can imagine a chair. Okay, a wired chair. Okay, a chair which is made up of wires. Okay, so if you would have seen the wires, how are the wires? The wires are crisscross. Okay, so they are crisscross. Okay, so one will be going in one direction. The wires, one wire will be going in one direction, and the other wires will be going in a different direction. Okay, so why they are providing the wires in a crisscross one? So that when a person sits, it can bear the weight. So similarly, nature has provided the abdomen with three abdominal muscles, okay, so that it can contain the abdominal organs within the abdomen. Okay, so it can hold the abdominal organs within the abdomen and it cannot herniate. Okay, so external oblique, internal oblique, and transverse abdominis. The next muscle is it's not a muscle, it's actually a fascia, which is the fascia transversalis. Okay, once you cut through all this muscle, you can see a fascia, which is called as fascia transversalis, also called as transverse fascia. And next to that will be the peritoneum. Okay, and inside the peritoneum will be the organs, the stomach, the small intestine, large intestine, liver. So all the structures are located inside the peritoneum. The peritoneum has got parietal and visceral layers. Okay, it's a very important layer, and there is a separate lecture on peritoneum. Now let's see what are the structures which are located on the medial side. As I said before, the skin, the superficial fascia. The next one, the anterior wall of the rectus sheath. Okay, the anterior wall of the rectus sheath. Okay, and once you cut through the anterior wall of the rectus sheath, you come across another muscle which is going from up to below, so which is called as rectus abdominis muscle. Okay, rectus abdominis muscle. So you can see the rectus abdominis muscle. Okay, and in the lowermost part you can see another one small muscle. This is called as pyramidalis because it looks like a pyramid. Okay, it's called as pyramidalis. Okay, pyramidalis. Okay, so rectus abdominis, and this is the pyramidalis. Okay. Then once you remove the rectus abdominis muscle, you will be able to see the posterior rectus sheath. Okay, the posterior rectus sheath. Okay. Now, if you observe this posterior rectus sheath, the posterior rectus sheath is ending here. Okay, it is not extending throughout. Okay, so this is the umbilicus, pubic symphysis. Just below the pubic symphysis, it extends and afterwards it disappears. The posterior rectus sheath is not seen. Okay, just keep remember this. I will tell you why it is like that. Okay, and next to it will be the fascia transversalis. Next to the fascia transversalis will be the peritoneum. Okay, so these are the medial structures. Okay, now the abdominal skin, it is thinner. Okay, and they follow the Langer's one. Okay, and usually the the incision is made along the cleavage line. Okay, so that the healing will be better and the scar will be less. Okay, the scar will be less. Okay, so for example, in during the gallbladder surgery, they will be making an incision, okay, on the upper part below the subcostal region, and more commonly like in C-section, okay, in cesarean section. Okay, in cesarean section, they will make an incision just above the pubic symphysis. Okay, and then they will open up the uterus to deliver the baby. Okay, so the incision for the cesarean section, it's usually horizontal. Okay, it's not vertical. Okay, it is usually horizontal along the cleavage line. Okay, usually it is done along the cleavage line. Okay, unless it's an emergency. Okay, or if the organs are not accessible, then they might go through different incisions. Okay, now let's see the superficial fascia. The superficial fascia of the abdomen, okay, it's made up of fat. Okay, it is mainly made up of fat, and unlike the other areas, there is no deep fascia. Okay, there is no deep fascia, or the deep fascia is very thin. Some books say that the deep fascia is very thin. Okay, some books say there is no deep fascia. Okay, so Snell says that there is no deep fascia. Okay, so you can take it, there is no deep fascia. Okay, but Keith Moore says that there is those thin deep fascia. Okay. Okay, so why there is no deep fascia? Because imagine if the deep fascia is present, the deep fascia is thick, and once again they will not allow the abdomen to expand. Okay, they will not allow the abdomen to expand when we eat. Okay, so that's why there is no deep fascia. Okay, not only when we eat, during the pregnancy. Okay, during the pregnancy, what happens? The fetus needs to grow. Okay, so the abdomen needs to expand. Okay, so that's why there is no deep fascia. But the superficial fascia is more modified, and you can identify two layers of the deep fascia. Okay, so next to the skin there will be a fatty layer, and next to the fatty layer there is a membranous layer. Okay, a fatty layer and a membranous layer. The fatty layer is called as campus fascia. Okay, and the membranous layer is also called as scarpa's fascia. Okay, campus fascia and scarpa's fascia. Okay, the membranous layer will be continuing in the perineum. Okay, that in the groin. Okay, the membranous layer will be continuous in the perineum, and there they are named a different one, which is called as Colles fascia. Okay, Colles fascia. Okay, now this is very important. Okay, and we will be discussing about this in the applied anatomy later on. Okay, so fatty layer, membranous layer, and Colles fascia. Okay. Now, there are a large number of superficial veins in the fatty layer. Okay, a large number of superficial veins you can see. Okay, and usually we will not be able to see it because of the huge amount of fat. But whenever the abdomen is tense, okay, say if there is during pregnancy, okay, or during if the person is having a fluid inside the abdomen, which is called as ascites, okay, where the abdomen is enlarged, okay, and in those conditions the superficial veins will be more prominent, okay, will be more prominent, okay, and usually the superficial veins above the umbilicus, they will go and drain into the axillary vein, and below the umbilicus they will go and drain into the femoral vein. Okay, so above the umbilicus they go into the axillary vein through the lateral thoracic vein, and below the umbilicus it goes into the femoral vein through the superficial epigastric vein. Okay. All right, so the arrows are showing the drainage. Now, here you can see I have asked you a few questions. Identify the origin and the drainage to show the arteries. So here you can see the superficial vein going through the lateral thoracic vein into the axillary vein, and below the umbilicus it is going through the superficial epigastric, okay, and then finally draining into the femoral vein. Okay. Now, what is caput medusa? Okay, and what is the anatomical reason behind it? Okay, so caput medusa, you know Medusa. Okay, Medusa is a Greek character. Okay, in the old and ancient thing, there will be a Greek person who is called as Medusa, and you know that he has got snakes in his head. Okay, he has got snakes in his head. Okay, so similarly, okay, so caput means head, Medusa, the head of the Medusa. Okay, he has got snakes on his head. Similarly, here the anterior abdominal wall veins, they will be going in all directions. Okay, and this caput medusa is especially observed in cases of liver cirrhosis. Okay, cirrhosis of liver. Okay, you can see the dilated superficial veins, okay, all around the umbilicus. Okay, so there will be dilated superficial veins all around the umbilicus. Okay, and you know that the veins are tortuous, so they look like the head of the medusa, and that's why this is called as caput medusa. This sign is called as caput medusa. Okay, the caput medusa, in which the superficial veins, they are enlarged. Okay. All right, and they are present in uh, in liver cirrhosis. Okay, now this I give you as a homework. You try to find out what will happen if there is a superior vena cava block and an inferior vena cava block. Okay, I give this as a homework for you. Okay, so you can find out the reason. It's given in your SNELS. Okay, so how will you detect if there is a superior vena cava obstruction and if there is an inferior vena cava obstruction? Okay, so try to find this. Questions may come from this one also. Okay, the membranous layer. Okay, the membranous layer, it's also called a Scarpa's layer. Okay, so it is more prominent in the lower part of the abdomen, and it fuses with the deep fascia of the thigh. Okay, you know that the deep fascia of the thigh is called as fascia lata. Okay, it fuses with the deep fascia of the thigh. Okay, and this Scarpa's fascia extends into the perineum as Colles fascia. Okay, it extends into the perineum as Colles fascia. Okay, and covers the penis and scrotum in males and labia majora in females. Okay, and is attached to these organs. We will see about the collis fascia later. Okay, but what is the importance of this membranous fascia and the collis fascia? Okay, so here you can see there is Scarpa's fascia, which is marked in green color. It is extending from the anterior abdominal wall, and here the Scarpa's fascia is renamed as Colles fascia. Okay, and it is going and extending below. Now, what happens? You can see that it is investing the penis. Okay, this is the urinary bladder. Now, suppose if there is an injury to the urethra, okay, this is called as urethra. If there is an injury to the urethra, okay, a blow in the perineum, and if there is an injury to the urethra, what happens? The urine will be coming out. Now, when the urine comes out, it gets collected in the penis and the scrotum. Okay, and the scrotum will be tense. Okay, the scrotum will be tense. Okay, so we can find out, okay, where the injury has occurred. Okay, so usually a person with a perineal injury, they will come with the pain in the perineum. Okay, you need to ask them the history, whether he has passed urine after the injury. If he has not passed the urine, you need to examine the perineum. Okay, you need to examine the perineum and look for any swelling in the penis and the scrotum. Okay, so here this penis and the scrotum is swollen. Why it is swollen? Because the urine has extravasated, has come out. The urine from the urinary bladder is coming out and is getting collected in the scrotum and the penis. Okay, so this is one of the methods, clinical examination. During the clinical examination, you need to examine the perineum. So in case of perineal injury, because of the damage to the colles fascia, the urine may be, the urethra may be damaged, and the urine will be collected in the scrotum, penis, and it might extend inside the anterior abdominal wall as well. Okay, it might extend inside the anterior abdominal wall as well. Okay, so usually the patient will complain like, okay, I'm having perineal pain, perineal pain. Okay, you need to ask whether he has passed urine. Okay, so if he has not passed urine, it means that there is a damage to the urethra. So this is the usual kind of pain. Okay, the injury, how it can occur. Okay, so imagine a person walking down and there is a blow in the perineal region, or when a person crosses over a wall, okay, crosses over an obstacle but then lands in the perineum. Okay, it's a nasty injury and it can cause injury to the urethra. All right, so the external oblique muscle, as I said before, I have given you the origin and insertion. You can have a look into it later. But what I am going to concentrate now is in the lowermost part of the external oblique. The external oblique muscle is modified. Okay, the external oblique aponeurosis is folded back itself and it forms the inguinal ligament. Okay, the inguinal ligament, you know, it is extending from anterior superior iliac spine to pubic tubercle. Okay, now this ligament, where is this ligament coming from? This ligament is a part of the external oblique aponeurosis. Okay, external oblique aponeurosis. So the external oblique aponeurosis, in the lowermost part, it will be folded. Okay, it will be folded and it will form the inguinal. It will be thickened and forms the inguinal ligament. Okay, so here the direction, and these are the nerve supply. So because of there is no time, I'm just going out fast. You can have a go through it later. Also, another important point in external oblique, apart from the forming the inguinal ligament, there is an opening. Okay, there is an opening just medial to the pubic tubercle. Okay, just medial to the pubic tubercle, there is an opening, and this opening is called as superficial inguinal ring. Okay, it's called as superficial inguinal ring. Okay, so this is a superficial inguinal ring, and this is the inguinal ligament. Okay, why this ring is present? Okay, why this ring or a defect is present in the external oblique aponeurosis? Because there are certain structures which go out of this superficial inguinal ring, especially in males. You know, the testis in males is located outside the abdomen. Okay, and the testis, you know that it forms the sperm. The sperm has to go through the cord. Okay, it will go through this superficial inguinal ring, and then it will be connected to the urethra, which is located inside the abdomen. Okay, so that is why the superficial inguinal ring is located to to facilitate the spermatic cord to go through it. Okay, spermatic cord to go through it. Okay, we will discuss about this once again later during the hernia. Okay, during the hernia, this is important. Okay, the internal oblique muscle. The internal oblique muscle, okay, the direction, as I said, it's going upwards and medially. Okay, and these are the nerve supply, the transverse abdominis muscle and the aponeurosis going transversely. Okay, now I told you the posterior part of the rectus sheath, okay, in the lower part it is absent. Okay, now I'm giving you the reason why the posterior rectus sheath is absent. Okay, in the lower half of the abdomen. Okay, you can see here, this is external oblique and the external oblique aponeurosis. And this is the internal oblique and the internal oblique aponeurosis. And this is the transverse abdominis and the transverse abdominis aponeurosis. Now, in the lowermost part, these two tendons, okay, that is the tendon or the aponeurosis of transverse abdominis and the internal oblique, okay, the transverse abdominis and the internal oblique, they come anterior to the rectus abdominis. Okay, you can see the rectus abdominis here. Okay, these two tendons, that is the tendon of the transverse abdominis, the tendon of the internal oblique aponeurosis, they both come anterior to the rectus sheath and they join together. Okay, and they join together to form a stronger aponeurosis, and this is called as conjoint tendon. Okay, conjoint tendon. Okay, because why there is this conjoint tendon? Because you know that there is a defect in the external oblique aponeurosis. Okay, so whenever we cough or do weight lifting, okay, lifting some heavy weight, okay, there is increased intra-abdominal pressure. Okay, so this increased intra-abdominal pressure should not let the abdominal organs to come through the superficial inguinal ring. So nature has provided this conjoint tendon to strengthen the defect which is present in the external oblique muscle. Okay, the conjoint tendon. This conjoint tendon is also used during hernial repair. Okay, so usually they will stitch this conjoint tendon to the inguinal ligament. They will stitch it, okay, so that the hernia will not come out. Okay, so that is regarding the conjoint tendon. Okay, conjoint tendon. Okay, lastly, the rectus abdominis muscle. Okay, the rectus abdominis. Okay, so that's the origin and insertion. Okay, and if you see the rectus abdominis, it's not a straight muscle like sartorius. Okay, the rectus abdominis muscle is divided into small muscles. Okay, into small muscle fibers. Okay, and these muscle fibers are In between this, there are some tendinous intersections. Okay, you can see some tendinous intersections. Okay, so these tendinous intersections keep the rectus abdominis strong. Okay, you must have seen persons with six-pack, eight-pack. What is that? It is because of this tendinous intersections. If it is a straight muscle, it will not be strong. However, the muscle fibers here are broken down into small muscle fibers so that it increases the muscle mass of the abdomen. Okay, so imagine if there are two or three dry sticks, you can easily break down. Okay, but if these sticks, if they are smaller and if they are plenty, it will be very difficult to break them. Okay, so that is why there are tendinous intersections. Okay, you can see one tendinous intersection is approximately at the level of the umbilicus, one above it and one below it. Okay, sometimes there will be an extra one. Okay, and that's the another tendinous intersections. Okay, now this tendinous intersections, they are attached to the anterior rectus sheath. Okay, they are attached to the anterior rectus sheath, and that's why we are able to observe the 8-pack. Okay, so the 6-pack or the 8-pack, it's because this one is getting attached to the anterior rectus sheath. All right, so these are the actions. As I said before, they help in increasing the intra-abdominal pressure, and also during micturition and during defecation. Okay, imagine when you are going to washroom to pass stools, so you strain. Okay, when you strain, the intra-abdominal wall pressure increases. These abdominal walls, they will contract, increase the pressure within the abdomen, and that will force the contents of the abdomen to be released. Okay, so during micturition and defecations, the anterior abdominal wall helps. Also, the rectus abdominis helps in flexion. Okay, when you touch your feet, so you will be flexing your abdomen, and the rectus abdominis muscle helps in this action as well. Okay, they also help in expiration. Okay, in the respiratory module, you must have learned it is also an accessory expiratory muscle. Now the rectus sheath. Okay, the rectus sheath. So here, the rectus sheath, the anterior rectus sheath and posterior rectus sheath. This is the rectus abdominis muscle. Okay, now this is very important. If you see the external oblique muscle, internal oblique muscle, and transverse abdominis muscle. Okay, and that is the rectus abdominis. The center one, this is called as linea alba. This is called as linea alba. And this lateral margin, it's called as linea semilunaris. Okay, linea semilunaris. Okay, linea semilunaris. Okay, now let's see. The skin is going from one direction to another. The superficial fascia is also going from one part from right to left. Now let's see the external oblique, internal oblique, and transverse abdominis muscle. Okay, the muscles are present on the lateral side. The external oblique aponeurosis is going anterior to the rectus sheath. Okay, the internal oblique aponeurosis, it is dividing into two, an anterior part and a posterior part. The anterior part fuses with the external oblique aponeurosis and forms the anterior rectus sheath. The posterior part of the internal oblique aponeurosis fuses with the transverse abdominis aponeurosis to form the posterior rectus sheath. Okay, now you know that the rectus sheath is nothing but the formation of the aponeurosis. Okay, it is nothing but the union of this aponeurosis. Okay, so the anterior rectus sheath is formed by, above the umbilicus, it is formed by the anterior part, the external oblique aponeurosis, the anterior part of internal oblique aponeurosis. Now, here, posterior rectus sheath. The posterior rectus sheath is formed by posterior part of the internal oblique and the posterior the transverse abdominis. Okay, the posterior part of the transverse abdominis. Okay, all right. So now you know that suppose if I make an incision on the medial side, okay, I will come across skin, superficial fascia, linea alba, fascia transversalis, and peritoneum. Now, if I make a lateral incision, skin, superficial fascia, external oblique, internal oblique, transverse abdominis, fascia transversalis, peritoneum. If I make a paramedian incision, okay, that is not lateral, not medial, paramedian. Now, here skin, superficial fascia, anterior rectus sheath, rectus abdominis, posterior rectus sheath, fascia transversalis, and peritoneum. All right. So this is the end of this anterior rectus sheath. There are many other things which are located here. Okay, so I have given the name of some of the incisions. You need not remember all these things, but remember what are all the contents you will come through if you make an incision. Okay, say if I make this incision. Okay, this incision, what are all the layers? The first one will be skin, superficial fascia, a small portion of the anterior rectus sheath. Okay, and here will be the external oblique muscle. Okay, then what other layer? Internal oblique. Okay, so you need to remember the layers of the abdominal wall in each one of this incision. At least remember what is in the medial and paramedial. Number 2, number 6. Okay. Now the rest of them are for hernia, which will be covered by Dr. Kumar. Okay. Now you are led for the next session. Now after hernia, if you have still any doubts, you can go through my presentation and you can ask any doubts. Okay. This wrap-up session I will not be present. Probably in the next wrap-up session, go through this presentation, and if you have any doubts, you can ask me. Okay, so still there is time. Go through the presentation. Hernia also will be covered. Okay, and if you are having any doubts in the next wrap-up session, I will be there to assist you. Okay, all right. Okay. You can say present in your chat box and then you can log out. Okay.